All right, ladies and gentlemen, I'd like to welcome Dr. Masih Moyedi here today. I'm going to give a little brief-ish introduction. Masih received his PhD in pain neuroimaging at the University of Toronto, where he investigated the neural mechanisms of orofacial pain using MRI. His postdoctoral research at University College London, a place I know well, in the UK, investigated electrocortical correlates of pain. Masih is an associate professor at the University of Toronto Faculty of Dentistry, the University of Toronto's Centre for the Study of Pain Scientists, and holds a Canadian Research Chair in Pain Neuroimaging. He has received an IASP Early Career Research Award and holds funding from the New Frontiers in Research Fund, NSERC, CIHR, Ontario Government, CFI, and NIH, a lot of acronyms. He has active collaborations with groups across Canada, the United States, and Europe. He serves the pain community both locally, nationally, and internationally. And he's an editorial board member of the Pain and Pain Reports and serves as secretary of the Canadian Pain Society and was founding chair of the IASP Neuroimaging of Pain. He's now the secretary and runs the International Human Pain Seminar Series. He is a strong believer in community and mentorship and supporting trainees achieve their goals, championing EDI principles. Masih, who has chronic pain resulting from cancer treatment, uses brain imaging to study the mechanisms of acute and chronic pain in pediatric and adult populations. And specifically, his research uses a biopsychosocial lens to understand the contributions and interactions of these domains to the pain experience. Thank you, Masih.
Thank you. So I'm going to talk to you today about 3 lines of research that built upon each other. So I'm going to tell you the story of how we got to looking at the intersection of gender, pain, and body image. First, we'll talk about the neural underpinnings of body image. Second, we'll talk about body image and pain. And then as a third, we'll bring in the study that I really want to highlight today and I think is relevant to the overall theme of them. So first, let's start with the neural underpinnings of body image. So we do know that there are a lot of body maps in the brain. On the left, you have the primary somatosensory map from Penfield from the 50s. And on the right, you have the updated one from Gordon et al. In 2023, where they basically found that there are integrative sensory motor regions called the integrator effector regions here that integrate complex actions and really have remapped the way we see the brain. We also know that there are somatotopic organizations in various places in the brain, including the insula, which is a key pain region. But body maps really come from, or our understanding of body maps really come from illusions, right? So multisensory illusions allow us to understand how we perceive our body and how we perceive that body in space. The original ones were based on body ownership, this concept of whether this limb belongs to you or not. And they were performed with a rubber hand illusion. So effectively what you do is you hide the person's arm from them with a blanket, you have a rubber arm that is adjacent to it, and then you stroke their hand and the rubber arm at the same time. And that multisensory illusion, seeing the rubber arm and seeing the stroking and feeling the stroking, makes them feel like develop an ownership of the rubber arm, so that if you attack the rubber arm with a threat, they will jump. So that would suggest to us that they've now included that rubber arm as part of their body map, right? So you've modified that body map. And that's quite important, the idea that these maps are modifiable. So where are body part features encoded? The first one that I want to go over is this idea of, we have various body maps in the brain. One is called body image, and body image encodes this idea of the shape, the size, color, and other features of your limbs. So it's basically how you see your body. This is quite a clever experiment that was developed by Roger Newport. It's basically a mirror box illusion, but that's modifiable with augmented reality. So what you do is you put your hands in the box. Underneath the box, there's a camera that records your hands. And then what you see is a digital image of your hands, which goes through a computer, but it looks like it's real time. And what we do is we have the individual sit there while we stretch the finger. So all I do is I pull on the finger, but we've digitally designed it so that it makes it feel like the finger is stretching, as you see here. And if you've ever done something like this, you'll find that people get quite distressed. There's quite a stress response, and they really believe that it's happening. So we wanted to understand the neural underpinnings of this because no one had ever found the neural underpinnings of body image. So the first thing we did is an illusion versus a control stimulus. And what we found was that people believed the illusion mostly. Some people were skeptical. The highest skeptics turned out to be the most robustly inducible. But effectively, we were able to elicit the illusion. We used this to develop a susceptibility or suggestibility score. And then we used that score to look at the brain. And what we found is that gray matter region in the right extrastriate body area, which is a functional brain region known to be involved in body maps, was activated. So this is a region that if I show you a bunch of hands and then I show you a bunch of houses, it'll light up to the hands, but not the houses. And that's actually exactly how you develop a functional map of where it would be in each individual. And then we looked at the gray matter and we found that the gray matter in that region was actually very strongly associated. If I can get correlations like that in all my studies, I'd be delighted. Very strongly associated with the gray matter volume in that region. We then wanted to see which brain regions were functionally involved. And here we did this illusion where we pulled the finger, right? So we did the stretch and then we pushed it back. So we would stretch the finger, hold it, and then push it back. Obviously, nothing is actually happening. The participants are just seeing their hand, but they're seeing their hand change. And so this involved a lot of work for adapting that mirror box to the MRI, but we successfully did it. And then we had a control condition where I would do the pulling, but there was no change to the hand as well. So these were the two conditions, the illusion and the control. And then what we found is your typical body map brain regions. So you have the extrastriate body area, the posterior parietal cortex, the premotor cortex, and the FBA, which is the fusiform body area. So this is your standard map of body image. Keep that in mind because it'll be important as we move forward. We also tried to understand this idea of where the extrastriate body area was talking to in the brain when encoding changes in body image. So really what we did is this idea of a functional connectivity. So what two brain regions are connected functionally, or have their activity correlated during the task, and which of those regions is associated with the strength of the illusion. And ultimately what we found is that this posterior parietal cortex connectivity with the EBA encoded the susceptibility to the illusion or changes in body image. So that's to give you a foundation of where body image is encoded in the brain. Now let's move on to body image and pain. So why did we study this, right? I'm a pain scientist. Why am I looking at body maps in the brain? Why do I care what happens when I change the hand? Well, that's all based on this one study by Roger Newport. And this is a really wonderful study where Roger basically used the mirage illusion on patients with osteoarthritis of the hand and basically either stretched their hand or shrunk their hand. And what you see on the right is that participants rated a 30 to 40 point drop in their pain when you change the hand image, right? That's quite robust. Changing the way they perceive their limb that is in pain reduced the amount of pain they were in. That's not trivial because I would kill for a drug that would reduce pain 40 points out of 100, right? I think clinicians here understand the value of that. And so the question is, why and how is that happening, right? Is there a brain process that is maintaining this abnormal image of the limb? And if we disrupt that loop, can we then start to use that as modifiable target for pain? And so my colleague Jenny Lewis in Bath studied CRPS and was the basis of all this work. And so for those who might not be familiar, CRPS usually occurs after soft tissue injury or fracture. Characterized by very severe pain, swelling, and loss of range of motion and temperature changes. The pain is not, in our opinion, not my opinion, clinician's opinion, who I'm citing, is not concordant with the injury that you see. So there is something more going on. Most CRPS cases recover within 12 months, but some continue persistent or chronic pain, and this becomes a long-term condition. And these patients are characterized by a perceptual change in the affected limb. So they really have changes in body image. They don't like the appearance of their limb, so they develop some dysmorphia. And some patients go so far as to lose ownership. They see the limb actually as a burden, and they're like, this isn't my arm anymore. Right? So the loss of function leads to a loss of ownership. And so some still go so far as to ask for amputation. And if that's not done with the appropriate perisurgical care, they can develop phantom limb pain as well. And Jenny Lewis developed a scale called the Bath Body Disturbance Scale, which she used as her outcome measure for this study. So the first question we know is that, is pain related to body perception disturbance? On the left here, you see that pain is actually nicely associated with body perception disturbance. So the more you perceive your body as abnormal or you're not happy with your body, the more pain you have. Similarly, your 2-point discrimination is worse if you have more body perception disturbances. And finally, the longer you have pain, the more body perception disturbances you have as well. So these would suggest that these are progressive events that happen that can start to deteriorate your body map and therefore your sensation of pain and 2-point discrimination. function. But ultimately, the question really did come in CRPS, if we reduce body perception disturbances, can we reduce pain? So Jenny did a RCT with multiple exposures. After the first exposure, what she found with doing this manipulation was just quite simple. We had the patient come in at a behavioral session. We asked them what they wanted, what their hand to look like. And we basically adjusted their hand the way they wanted it to look. We changed the color, we changed the size, we changed the shape, however they wanted it, however they saw their ideal hand. We made those modifications. And by doing that after a single exposure, you saw that there was about a 12 to 15 point drop in the body perception disturbance. And the reason that that's relevant, this illusion is different than the one I showed you before, in that one, we're not just changing or distorting the hand, we're making it look the way they want it to look. But two, we've added color. And there's some mixed evidence out there that adding color to an illusion somehow reduces its believability or suggestibility. We're not sure why. We think it might be an added channel of information that might create more skepticism or give you more cues that things might not be real, but we're not sure about that. So we're looking into that a little bit more. Nonetheless, Jenny performed this illusion, and then you also saw a very modest but real change in pain intensity. Again, very, very modest. But after repeated exposures, so I think they had 10 sessions, you saw a little bit more robust of a drop in pain intensity. Nothing significantly huge that would be clinically meaningful. It's about, 15 out of 100. But ultimately, patients did report that they did prefer their limb, right? The changes in body perception disturbances, changing the body image, resulted in reductions in pain. And the question is, how do we build on that, or how do we think about that? So quickly, a single exposure led to a decrease in body perception disturbances, improved their liking of their limb. They reported it as being lighter, which is often a case where like, oh, it's a burden, it's heavy. There was no change in the ownership of the limb, so they didn't necessarily feel it was theirs. And I wonder if that's, again, because of the color or because there weren't enough sessions. But most importantly, there was a reduction in pain. So, as a scientist, I think this is really cool. It's a really great way to understand the neuromechanism of what's going on, but it's not really target that I think you guys would want to adopt in clinic, to buying this expensive machine and repeated exposures. It's too expensive for the trade-off. But what we can do is use this as a means of learning about what's going on in the neuromechanisms to find other modifiable targets. We know that pain is associated with body perception disturbances. This is in that cohort that we collected as a follow-up. So Jenny did that in a behavioral session. In a follow-up study funded by Arthritis UK, Jenny did the exact same experiment, but then brought them to the scanner. And then we saw what happens in the brain when we modify their body image against controls. So importantly, we know that there's a relationship between body perception disturbances and pain intensity in this cohort that we're looking at. And what we found is that, surprisingly, we found this extrastriate body area bilaterally when they're looking at their own hand. And that's quite nice to find, but it was one of the few regions we found in the brain that activated in response to the illusion. So you're not getting the entire network of the body map. You're really just getting these two regions as a consistent activation. And that's surprising to us. Then Matt did this, Matt, my student who's working on this data, performed a resting state functional connectivity analysis. And what that means is a resting state scan is when we put someone in the scanner, have them lie down and say, don't think about anything in particular. Just let your mind wander. And the idea there is that your brain will fluctuate along, hum along as it does when you're bored or not doing anything. If you've ever been in an MRI scanner, I wouldn't call it without stimulus, because there's quite a bit of and noise and such. But at the end of the day, none of it is structured noise to you. None of it is meaningful. So you're just lying there, getting bored, hoping not to fall asleep so that you can get the data out. But what we do with that data is assume that it means that it reflects the functional architecture of the brain. So can we use MRI or fMRI to look at activations? We can use it to try to look at the functional architecture and the functional setup of the brain and individual differences in those setups. This was originally discovered by Biswal, the late 90s. There's this idea that if you take one brain region, take its activity, and then project it to the rest of the brain, you're going to find another region that has activity that hums along at the same frequency or activation pattern, I guess is a way to say it. And so here, for example, the right M1 and the left M1 are highly correlated at rest, right? So you're not actively involved in any bimanual task or single manual task, but your two motor cortices are humming along and talking to each other when you're not engaged in much else. So we decided to look at the EBA with regard to all the other brain regions we know to be involved in body image. And what we found when we were looking at patients with CRPS versus controls is that there were differences in, surprisingly, the somatosensory cortex and the visual cortex, which are the two channels of input for these illusions, right? So the somatosensory cortex is your tactile input and it's your map of your limb, and it's in the hand region. And your visual cortex, which was also surprising because the visual input is what basically drives these illusions, especially in this one where we don't have tactile feedback. And so what we find is that there's differences in these maps or the connectivity with the EBA with these key regions that's quite remarkable. But more importantly, you also see that patients have less activity in the amygdala. And the amygdala largely is a negative affect brain region, but it also exerts a lot of inhibitory control on limbic processes. And so we think the absence of deactivation of the CRPS in patients compared to controls suggests that we're likely seeing a disinhibition of the limbic networks, but that needs to be dug into a bit further. The next question we ask is EBA connectivity associated with body perception disturbances? And again, what we found is that the extrastriate body area activity was, and the fusiform body area, which is a similar region but a bit more complex, are abnormally connected with the right somatosensory cortex and the left somatosensory cortex, effectively telling you that, the chatter between the extrastriate body area, which encodes images of your body, or the fusiform body area, which encodes more complex images of a limb or body, are abnormally talking to the somatosensory cortex, right? So there is a dysfunction there that's correlated to how much body perception disturbances you have. So the more disturbance you have, the more abnormal the connectivity is. And that's quite remarkable. Then we tried to see if there was an interaction between body perception disturbances, pain intensity, and EBA connectivity. And again, what we found is that these regions that are involved in body maps are abnormal, right? So the somatosensory cortex is abnormally connected with the EBA. The bilateral EBA are communicating differently amongst each other. And then the premotor cortex, which is largely involved in body schema or body ownership, has abnormal activity in these patients. So as an interim summary, what we've learned so far is that we can manipulate body image in healthy individuals and in chronic pain. Changes in body image are associated with decreases in pain intensity, and changes in body image are associated with the extrastriate body area and its connectivity to other body mapping areas. More interestingly for me, the interaction of body perception disturbances and pain intensity is associated with network activity between body map areas. So this tells us that we might be on the right track, right? These body map areas are abnormally functioning in patients with CRPS and have different connectivity based on their symptomatology, right? So this tells us that perhaps targeting body image might be something to do. So this led us to our third study, which got us interested in thinking about pain and body image. And more specifically, we know that there's a link in pain and body image. I think I just made that link, hopefully convincingly. But now the question is that somehow modified or associated with gender? I'm pretty sure everyone here knows this, but just in case, we know that there are sex differences in the incidence of chronic pain. Women are much more susceptible to chronic pain than men, that there are physiological differences at the level of the primary afferent. So Frank Parecka just published this year in Brain, showing that the primary afferents are actually sexually dimorphic for nociception, and that the modulatory circuits, Karen Davis at Toronto Western at the Krembil, has shown that the modulatory circuits are sexually dimorphic as well in males versus females. But sex and gender are not the same. Although we use them interchangeably all the time in the literature, or we used to, and people still do, they are not the same. Gender is a set of socially constructed roles, behaviors, or expression, identities of girls, women, boys, and gender and sexually diverse people. Gender, we know, influences how people perceive themselves and others, how they act and interact. And the distribution of power and resources in society is very much gender-based as well. We also know that gender also has a significant impact on health and well-being above and beyond biological sex differences. Right? So your lifestyle factors that can basically be modified by gender or shaped by gender basically increase your risk of non-communicable diseases over time. If anyone's interested in gender work, this Gendered Innovations at Stanford University is a remarkably phenomenal resource that teaches you all about these different aspects of gender. So sex and gender in pain, we know that gender role expectations of pain questionnaire exist, and we know that it shows that there are differences based on pain sensitivity, the endurance to pain, the willingness to report pain relative to the typical man or woman. So it really measures these different factors and your attitudes towards them and where you fall along that scale. And there's evidence that the gender role expectations of pain questionnaire better predicts. And in fact, when you put sex and gender roles and this questionnaire scores in a model, most of the variance is taken up by the gender roles expectation of pain questionnaire, and they predict pain tolerance and pain unpleasantness much more robustly than sex, right? So I think this whole idea of there being sex differences is important, but we can't ignore this idea that gender and the psychosocial aspect of things further influence and might be more important than sex differences in understanding pain in patients. The other finding that's quite interesting and I found quite remarkable is that trans women might respond to pain more similarly to cis women than cis men. And that's something you see here. Trans women are at the top cis women are in the red dots just underneath, whereas the cis men are the blue dots lower. And what you find is that when you repeat pulses of heat and they give you a rating between 0 and 100, trans men and cis women have very similar ratings that are not different from each other, but both are different from cis men. So there's this idea that gender is probably very important in understanding pain, and gender might actually better reflect individual differences or capture individual differences amongst the population over sex. But there's very little data to establish this, right? There hasn't been enough experiments. In fact, when we all write our CIHR grants or NIH grants, we tend to write, we're going to collect gender, and then hopefully we'll have enough data eventually to aggregate data and find like some relationship that we haven't thought about yet. And it's quite disappointing, but in reality, that is all we can do at the moment. So we came up with a different experiment. In doing my reading about this, what we came up with is this idea that there's a similar surgery that happens in two populations, and that's mastectomy. You can have mastectomy for gender affirming purposes in trans men and non-binary individuals. And you can have mastectomy for cancer prophylaxis. You can also have it for cancer, but we're talking about prophylaxis here. And what we found is that those who do it for gender affirming purposes have a decrease in body image disturbances. So they end up liking their body more. But they're also at remarkably low risk of post-surgical pain. The reports I read is that most patients don't require opiates post-surgically after a mastectomy, and that they recover quite well and don't develop any post-surgical pain in the long run. And if they do, I think the risk is like less than 0.1%. Whereas in cancer prophylaxis, body image disturbances are quite robust. I think 40 to 60% of them develop body image disturbances, being unhappy about their breasts, the shape of their breasts, the sensations around them. But also the rates of post-mastectomy pain syndromes is remarkably high. I'd never known this until I was speaking to James Kahn, who works at Sinai, that 40 to 50% of women at Sinai after mastectomy develop post-surgical pain that's persistent. That's huge, especially within rates of breast cancer that we have. That's a remarkably high number. So why the difference, right? What's going on? So we proposed a New Frontiers grant, and that's why it was in my bio, because it's relevant to this, where we said, hey, this might actually be more interesting than we think, because it could simply be trans men and non-binary individuals might be taking hormones, and we know that hormones can modify pain sensitivity, and testosterone can be analgesic. It could also just be the change in body image, right? You like the way your body's going. The meaning of the surgery is more important. By improving body image and creating a positive context of the surgery, you end up not developing post-surgical pain, right? We all know that your psychology peri-surgically can very much affect the outcomes. Where in cancer prophylaxis, it's a scary thing, right? What I'm learning very quickly is that these patients are told you're at high risk for cancer, surgery's in 2 weeks, right? They don't have the time to, like the gender affirming care folks who have to go through months or maybe years before they have access to the surgery. This is quite quick and sudden. They don't have time to really go through the peri-surgical care or pre-surgical care to prepare themselves for such a huge change. And so that's quite interesting. Alternatively, it could be because access to gender affirming care is so precarious that they're just not reporting it. Right? They don't want to lose access. They don't want to be the person who the activists lobbed onto and said, hey, we lost access to surgery because of this person. So they just might be underreporting it to protect their community. And that's quite damning, frankly, in my opinion, right? So put together a New Frontiers grant with Women's College and the breast surgeons there and the trans-related surgery clinic there to try to really understand this relationship and unpack it. And as a first step, I basically called up Caitlin Berner and we developed this model based on her expertise. But my student Batu Kaya really did do the heavy lifting. These numbers are all references that support all these links, but you'll have to go to the paper to find them because there's no room for all of them on the slide. But ultimately, what we did is developed a proposed integrated framework of the relationship between sex, gender, body image, and chronic pain and how psychology can affect that. It's in press and pain. And so the study that we're performing is really to understand whether this relationship between mastectomy and pain is mediated by body image. And so what we're doing is quite a big complex study where we basically get a referral from the MD or nurse practitioner, we consent, and then we get a bevy of baseline measures. We measure their pain sensitivity. We get a whole bunch of questionnaires about body image, about pain cognitions, various other measures. But our key outcome measures are how much pain they're in and their body perception. We do a qualitative pre and post interview to understand the relationship with their body and their medical care and their care team, as well as their pain and their history of pain, both before and after surgery. At an acute follow-up about 1 week post-surgery, we get a quick measure of our outcome measures, which are body perception disturbance and pain. And at long-term, they come back in for a full second visit. And one of the things that we do that I'm quite excited about, but that's because I do imaging and I love imaging, is that we're also asking them to do a body image task in the scanner, where they either see We've slightly modified it from this, but in this example where I'll show you the data, we show them, we ask them to send in a picture of their chest at pre-surgery. And then post-surgery, we ask them to send in a picture of their chest post-surgery. And at pre-surgery, we show them their chest, and then we show them an object or a flower or something. And we basically say, to what extent do you feel that this image reflects your body, right? And what we expect is that it would be discordant in trans men at baseline, but concordant in cis women. And then at post-surgery, what we expect is the opposite, right? For trans men to say, hey, I like this better. This is more like what I want. And for cis women to say, this is not what I want. This is not what I had, and I'm not happy with it. And we expect that to be reflected in brain activity. And so let me give you some preliminary data. So this is an ongoing study. This basically, the data I'm showing you are pilot data that we were able to collect thanks to the New Frontiers grant. But now we're submitting it to CIHR for a much larger study, or we submitted it to CIHR. We'll find out. Interestingly, pre-surgically, there was no difference in the pain between the groups. 1 week follow-up, although this question's a little odd because it's 4 weeks average, but at 1 week follow-up, the cis women report more pain. And at 6 months follow-up, they continue to report higher pain compared to the trans and non-binary group. In summary, cis women show greater pain intensity at 1 week and 6 months follow-up. And then there's this concept of pain modulatory capacity, which is how good is your body at intrinsically modulating signals? And the way we measure that is 2 simple tests. 1 is temporal summation to pain. So you do a repeated pinprick stimulus. And as you repeat that stimulus, it becomes more and more painful. In most people, some people, it doesn't get more painful. But the extent to which it becomes more painful is reflective of your capacity to undergo central sensitization or for things to become more painful. And then the other test is conditioned pain modulation. This is a classic one that you've probably all heard about. You stick your hand in an ice bucket as a conditioning stimulus. You then get a test stimulus at a heterosegmental level. And the idea is that this conditioned stimulus, we believe, releases tons of endogenous opioids, although there's now evidence that it also might have other pain modulatory molecules involved. And the extent to which you can reduce the test stimulus before and after the conditioning will give you a sense of how well they are able to engage that system, to that analgesic system. And like most of the tests in pain, there's a huge individual difference. Some people cannot engage their descending modulatory circuits, and others are very, very robust at it. And what we find here is that at baseline, cis women are not really engaging the capacitory modulation, but at 6 months, they have a very modest modulation occurring. And that's quite surprising to me. Whereas in trans and non-binary folks, at baseline, they have a poor modulatory capacity that is much more robust at 6 months. Altogether, we show that there's lower pain modulatory capacity in cis women at 6 months. Finally, the other major outcome we have is body image. And what we find is that cis women on this body appreciation scale really stay steady, whereas trans men and non-binary individuals have a much marked increase in their body appreciation. That the MBSRQ is basically how happy are you with the appearance of your breasts and your chest. And cis women, again, steady in the group we have, but this is a sample, I think, of 4 subjects at follow-up, whereas in the trans men and non-binary group, we have 15 participants. And so what you see is a marked improvement in the trans men. And what you also see is that there's a marked improvement in body image in both groups as well, but more significantly in the trans men as well. So over time, there's less BIDs and body image in the trans men and non-binary group. There's some more BIDs. So you can see here, they kind of stay steady in the cis women. I might have overinterpreted that one a little bit for that. So what does it look like in the brain? Well, this is very preliminary data. I'm not doing any contrast because it's too small, but effectively what you see is that the extrastriate body area is activated in both groups. The posterior parietal cortex is activated in both groups, which is surprising because they're not overlapping, right? You're seeing adjacent activations, but not overlapping activation. That's quite remarkable. But importantly, what we see is that affective and salience regions are activated in trans non-binary group and not cis women. So effectively what we're seeing, negative affect type activation when these individuals see their chest. And finally, and I think most importantly, what we see in controls but not patients in cis women and not trans and non-binary individuals is a body ownership activation of the posterior cingulate cortex. So the idea here is that cis women see those images and say, hey, that's my body. And that's shown here in the PCC. So there's neural underpinnings of what they see. Trans men don't have that activation. So that's quite remarkable to me, right? So there might really be a sense of like, this is not my body. So TNB, trans and non-binary individuals show activity in attention negative affect regions differently than cis women, and cis women show activity in canonical body image and body ownership areas. So, talk to you about 3 different stories that have built on each other and taken you along the journey that my lab went through to get here. And I just want to give you one final take-home message, which is that I believe that gender affirming surgery improves mood, which I didn't show you, but in every case, the mood of the trans men got much better, lower anxiety, lower depression, improved their pain, improved their pain modulatory capacity, and improved their body image. So the significance of this for me is that gender affirming care improves the individual's quality of life. They are much better suited in a much better place than before surgery. And gender non-affirming care, so mastectomy for cancer prophylaxis, typo, is associated with increased pain and reduced body image satisfaction. So what we can do in this case is actually learn from the gender affirming care and take lessons from that and try to apply them to the cancer prophylaxis team to try to improve their outcomes. Maybe the trick is that you have some counseling sessions before surgery and you prepare them for the outcome. And it's not as rushed, but you really discuss what changes to expect and how to soften the blow of what's going to happen, and then help them through different types of therapy to improve their mindsets before and after surgery. So I just want to thank our funders and my lab, and Matt, who's leading the imaging work on the CRPS, and Batu, who's there in the middle, who's leading the work on the trans non-binary and cis women work. Thank you.
Thank you, Massey. I really enjoyed that. Great. I have a, maybe it's more of an observation than a question. I mean, I'm on the acute pain service. We talk about 3 Ps, can't even remember them: pharmacological, psychological, and physical. And I'm a simple guy and I just concentrate on the pharmacological. But this sort of reaffirms to me that if one's talking about chronic pain, the more we deal with the psychological, the more we focus on that, we're barking up the right tree. And the more we do concentrate on the pharmacological, then I think we're not going where we should be going.
Yeah. So you hear me in the back? It's okay. So the evidence in imaging suggests that as pain transitions from acute to chronic pain, the brain networks that are involved in encoding that shift from sensory and sensory discriminative networks to limbic networks. So what you really see is that pain becomes an affective disease when it becomes chronic, rather than a sensory disease, which is what we normally treat with pharmacology. So, so I think that there is something to be said about thinking of pain as a sensory affective disorder. Chronic pain really is a more affective than sensory disorder that might really help us understand and develop a better paradigm.
Any questions out there?
Hi, Massey. That was a really fantastic talk. I have a question about the first part of the talk, and I'm wondering what your sense is of how the body image correlation would apply to conditions where there's not as much of a visual representation of the pain. Like in the CRPS, the limb is very visibly swollen. It's very red. You kind of have a constant reminder in front of your eyes that of your condition. But a lot of chronic pain, you don't have that same degree of visual representation. So I'm wondering if you think that changes based on the physical presentation, how that.
So a year ago, I would have been like, yeah, absolutely. If you see it, it's much worse. And then Tasha Staunton from Australia came out with a really surprising data set that if you manipulate using a mirage-like illusion, images of people with low back pain, I can't see my lower back. But if you modify the image of the lower back pain to show that it's stronger or that it's more muscled or any sort of transformation like that, the pain plummets. So it's not only about the way you can see it and the reminder that things are abnormal. It's something about the nociceptive signal that modifies the body, that then if you distort that modification somehow, that feedback loop is broken. I was really surprised by those data. And then Tasha came and I grilled her about it. And she's like, yeah, no, I was surprised too. And so we're thinking about what that means and how that works. If these people have pain on the back and then you show them their back and then you modify it, that's what's driving the difference. So you're showing them their back and then modifying it. So maybe it's making it more present or making them think about it, but we don't know. The other thing with Tasha's work, like I said, it's the first time I did this illusion myself, and the first time you do it to someone, you get a massive stress response, right? We know that acute stress can be quite analgesic, so it could just be that. So what we definitely need are some longer term or repeated exposure type RCTs that are properly controlled so that we can determine what's actually happening. But it's a really important question. As I train in orofacial pain, I often think about stuff like that. Like, is orofacial pain worse because you can't see your face? Or is it not, like, or is it worse because the tissues are different or something? So it's that sort of thing that I think about a lot, probably more than you do, but it's kind of stuff that I enjoy thinking about. I want to develop studies to answer these questions. And I think that that's where Mike might agree with me, that this is stuff we can do in humans, but not in rodents, because I wouldn't know how to treat a rodent's body image. But, we can try.
Thanks for your talk. My name is Julia. I'm a physiotherapist in the pediatric chronic pain clinic. And a comment about the work on body image and what we see in children. So in physiotherapy, we use mirror therapy, which is sort of an illusion. And yes, with CRPS, it can be a really strong illusion because their affected body part does look so different. And I'm just sort of wondering what your thoughts are of what you would sort of hypothesize in children. What we see is that children can actually be very suggestible. So when they see an altered image, that it might be more believable to them than an adult, and whether that might have a different effect in children. But on the flip side, sometimes they can have an extremely emotional response, and they have maybe less capacity to sort of process that image. So yeah, just wondering what your thoughts are, what this might look like in children.
Next question. I don't know the answer to that. I can speculate. My speculation would be that it could be effective in children if they're prepared to see what they see, and that you explain to them that this might be shocking, it might be surprising, but we want you to focus on the feelings that your body has, and not so much the emotion around it. And just maybe try to bring what they should be focusing on to try to reduce the emotional impact. But it is an emotional experience. Like when we did this in the scanner, one of the people we did it in came out for the next hour and was just touching her hand, confirming that it hadn't changed. It was really visibly distressed. Don't tell the ethic. But ultimately, there is a sense that you're changing your body, and it's something that we feel that we have complete control over and we understand. So all of a sudden, this thing is happening at so quick. But yeah, it's one of those things that I think we have to think about and I think perhaps using this. So I don't think that we should necessarily use a mirage illusion. I think what we can do is target through psychotherapy or something of the sort, body image and targeting body image through that talk therapy or something of that sort, or even VR where they're immersed in the world and see their limbs different with different tools and stuff might be more effective because it's not their body that's changing, it's the function of their body in an avatar. And those things might be more desirable to them. But I also think that the idea of targeting body image through therapeutic approaches or therapy rather than visual illusions might be working. But I don't know how effective therapy is. Imagine not being a kid. I don't know much more about that.
Do you have a question?
Yes, so thinking about this, one of the pain fellows here at SickKids, body image, you see a person living within their own body. If it feels different, then that image that they have imagined isn't what you'll describe it should be like.
Yeah.
So it's neurodiversity, it is gender dysphoria, it is pain and the experience of all these invisible things that people live with, feel different and are different. I wonder, body image is an important part of that. Have people looked at understanding when negative tests or negative imaging comes back? Can you track changes in people's brain if you are able to fully explain what is going on inside their body in terms of what that image means, not just a report, but actually showing people what their body looks like inside? Do you think that has a positive benefit to helping with their treatment?
Good question. I'd say that's a premise for a very big, expensive grant. I don't think anyone's on that one. I know that there's behavioral work in diagnostic uncertainty, for example, that talks about outcomes and how much worse it is. I don't think the link has been made with body image. Lauren Heathcote's doing some really wonderful work on body monitoring. So people who self-scan a lot. So she works a lot in kids who are cancer survivors, pediatric cancer survivors. And she's very much into understanding their psychology and their relationship with the body and how they overscan the body and they overfocus on certain stimuli and then other things are less important. This idea that their body, although it's something we feel we can control, now we're training them and it's a different entity than what they want it to be. So those things I think are emerging, but they're very, very decent. But I would strongly suggest you follow Lauren Heathcote's work on that. She's based at KCL or King's College London, and she does outstanding work. We're doing a pilot RCT in my lab on side funds, which I don't know where they come from, where we're looking at even the relationship with a physician and a placebo, and how much that psychosocial interaction affects the way they scan their body and the way they feel pain and the way they can modulate pain. And we're seeing these links that we never expected to see. So I think it's much, much more complex than you think it is. But to really start unpacking those links, you're going to need a huge data set, right? And that gets really complicated because you're going to have a lot of individual differences in the diagnostic uncertainty level and how they respond to it. And then based on the personal history around it, right? Like if you tell someone, oh, you have cancer, that comes with baggage, right? Of what we know and think about cancer. But if you say you have ankylosing spondylitis, I don't even know what that means most of the time. Neither will the kids. So they're like, okay. And then, so I think it's the sort of thing of like, what is the baggage of the diagnosis as well? And those sorts of things matter a lot. So the context is remarkably important, but it's very early phase.
Okay, I think I'm going to wrap it up there. And I want to thank Matthew again for his wonderful talk. Thank you.